The surgery was perfect. Textbook. The surgeon said so himself. Everything went exactly as planned. Raymond, 77 years old, retired history teacher, Portland, Oregon. Bad right knee for 6 years. 3 different orthopedic surgeons, 3 identical recommendations. Total knee replacement. Routine procedure. You'll be walking in 2 weeks. Day 3 after surgery, Raymond's right calf swelled. Blood clot. Deep vein thrombosis. Day 5, a piece of that clot broke free, traveled through his bloodstream, and lodged in his lung. Pulmonary embolism. Code blue. ICU for 2 weeks. Acute kidney failure from the cascade of medications used to save his life. 6 months later, Raymond can walk. Slower than before the surgery, more carefully than before the surgery, with more fear than before the surgery. His knee no longer hurts, but the rest of his body has not recovered from what the surgery did to it. The surgery did not fail. Raymond's knee is perfect. But Raymond nearly died. Not because of the knee, because his body, at 77, with mild heart failure, type 2 diabetes, and a BMI of 32, was never a good candidate for that operation in the first place. And nobody had that conversation with him. My name is Dr. Ethan Carter. I have been a general surgeon for over 20 years. I have stood on both sides of this problem. I have performed surgeries that saved legs, and I have treated patients whose lives were permanently changed by surgeries they did not need. Today, I am going to tell you about 5 leg surgeries that carry serious hidden risks for people over 60. I need to be absolutely clear about something before we begin. I am not telling you to refuse surgery. Surgery saves lives. Surgery restores mobility. Surgery can give years back to people who thought they had none left. I believe in surgery. I have dedicated my career to it. What I am telling you is that certain surgeries, in certain patients, under certain conditions, carry risks that are rarely discussed in a 15-minute appointment. And that the decision to operate should be the end of a thorough conversation, not the beginning of a quick one. A 2025 study published in BMC Musculoskeletal Disorders analyzed over 400 elderly patients who underwent hip or knee replacement and found that more than 30% experienced post-operative complications. The independent risk factors were age, body mass index, and hypertension. Data from the National Surgical Quality Improvement Program shows that the probability of a serious complication after knee arthroplasty increases from 4% in patients aged 40 to 64 to over 17% in patients over 90. After age 80, the curve steepens dramatically. 5 surgeries, 5 conversations your doctor may not have had with you, and 4 questions that could change your outcome. Let's begin. Surgery number 1, total knee replacement in high-risk patients. Let me be clear about what this surgery is when it works. Total knee arthroplasty is one of the most successful operations in modern medicine. Over 1.3 million joint replacements are performed annually in the United States. For the right patient, a new knee is transformative. People go from constant pain to playing with their grandchildren. I have seen it. I have been part of it. It is remarkable. But here is where the math changes. When a patient is over 75 and carries 3 or more serious health conditions, the risk profile shifts dramatically. Heart failure, diabetes, chronic kidney disease, obesity, peripheral vascular disease. Each one independently increases the risk of surgical complications. Combine 3 or 4 of them in a body that is already working harder than it used to, and you are no longer looking at a routine operation. You are looking at a physiological event that every organ in the body must survive. The most feared complication after knee replacement in elderly patients is venous thromboembolism, blood clots. Research confirms that older adults are particularly vulnerable to deep vein thrombosis after total knee arthroplasty due to age-related changes in the vascular system. A clot forms in the leg. It breaks free. It travels to the lung. Pulmonary embolism. In elderly patients with existing cardiovascular disease, it can be fatal. A large Korean study analyzing over 560,000 knee replacement patients found that congestive heart failure doubled the risk of in-hospital mortality. Myocardial infarction doubled it again. Renal disease increased it nearly threefold. These are not theoretical risks. These are measured outcomes from real patients. For many patients with painful knees and significant comorbidities, there are alternatives that have not been exhausted. Intensive physical therapy. Weight loss, even 10 to 15 pounds, which dramatically reduces knee load. Cortisone injections. Hyaluronic acid injections. Custom orthotics. Platelet-rich plasma therapy. Bracing. Each one can meaningfully reduce pain. None of them carry the risk of a pulmonary embolism. Raymond had mild heart failure, type 2 diabetes, and a BMI of 32. Each one of those conditions was documented in his medical record. Not one of the 3 surgeons who recommended his knee replacement discussed how those conditions changed the risk calculation. They discussed the knee. They did not discuss the body the knee was attached to. If you are being recommended a knee replacement and you have significant health conditions, ask this question. With my specific health profile, what is the realistic complication rate for this procedure? Do not accept a national average. Ask for your risk. It may be very different. Surgery number 2, and this is the one that patients are least prepared for. Revision joint replacement. The surgery to replace a replacement. Artificial joints do not last forever. Depending on the type, the patient's activity level, and their body weight, a knee or hip replacement may last 15 to 25 years. After that, the implant loosens, the plastic liner wears, the bone around the implant weakens. Infection can set in even years after the original surgery. When any of these happen, the recommendation is often revision surgery. Here is what you need to understand. Revision surgery is not the same operation as the original. Not even close. It is longer, it is more complex. The bone is weaker because the previous implant has been sitting in it for years. There is scar tissue throughout the joint. Blood loss is greater. The risk of infection is higher. And the recovery is significantly more difficult for a body that is now 15 to 20 years older than it was for the first surgery. Research shows that patient age and the ASA physical status score are the most important determinants of mortality following revision hip arthroplasty. The complication rates are substantially higher than primary surgery across every metric measured. And here is the conversation that should happen during the first surgery, but almost never does. If you are 65 when you get your knee replaced, that implant may need revision when you are 80 or 85. At that age, with the additional health conditions that come with aging, a revision surgery becomes a genuinely dangerous proposition. That future should be part of the present conversation. For patients over 80 with a loosening implant who have significant comorbidities, the question must be asked honestly. Is the pain and limitation from the failing implant worse than the risk of the revision? In many cases, the answer is yes, and revision is the right choice. But in some cases, pain management, activity modification, bracing, and acceptance of functional limitations may offer a safer path forward. Ask your surgeon directly. What is the mortality risk for a revision surgery in a patient my age with my health conditions? What does life look like if we manage this without operating? Surgery number 3. Peripheral bypass surgery in frail patients. Peripheral arterial disease. Narrowing of the arteries that supply blood to your legs. The same atherosclerosis that blocks coronary arteries, just happening further from the heart. When it progresses far enough, blood flow to the legs drops below the level needed to keep tissue alive. Pain when walking, then pain at rest, then wounds that will not heal, then gangrene. Peripheral bypass surgery creates a new route for blood to reach the lower leg, bypassing the blocked section. In the right patient, it is genuinely life-saving. It can prevent amputation. It can restore the ability to walk. But in a frail elderly patient with coexisting heart failure, chronic lung disease, kidney impairment, and diabetes, peripheral bypass is a major open surgery with significant cardiovascular risk. The operation requires general or regional anesthesia, often lasts several hours, involves clamping and rerouting major blood vessels, and places enormous stress on a heart that may already be struggling. A 2025 European Society of Cardiology consensus document on surgery in older adults emphasized the extraordinary complexity of managing thromboembolic risk during and after vascular surgery in elderly patients. The risk of heart attack, stroke, kidney failure, and wound complications is substantially elevated in this population. Here is what has changed in the last decade. Endovascular procedures, catheter-based interventions using balloons and stents, can often achieve similar results with dramatically less physiological stress. A thin catheter inserted through a small puncture in the groin, guided to the blockage, expanded with a balloon, held open with a stent. No large incision, no general anesthesia, shorter recovery, lower complication rate. And for patients whose primary symptom is pain when walking, not tissue loss, supervised exercise therapy has evidence comparable to surgical intervention. Structured walking programs, progressively increasing distance under medical supervision, can improve blood flow through collateral vessel development without any surgical risk at all. I want to be clear about this. If your foot has gangrene, if tissue is dying, if amputation is imminent without intervention, bypass surgery may be necessary regardless of your risk profile. That is limb salvage. That is not elective. But if you are at the claudication stage, pain with walking that resolves with rest, you have time, and you have options. Ask, is my condition threatening my limb right now? Or am I at the pain with walking stage? If it is not yet limb threatening, what are the non-surgical or less invasive options? Surgery number 4, and this one frustrates me more than any other on this list. Lumbar spinal fusion for chronic leg pain. If you are over 60 and you have pain radiating down your leg, there is a reasonable chance a spine surgeon has recommended fusion. The idea is straightforward. 2 or more vertebrae are fused together with metal hardware, eliminating movement at that segment, theoretically relieving the pressure on the nerve root that is causing your leg pain. For acute spinal emergencies, compression causing loss of bladder or bowel control, progressive paralysis, fusion is necessary and life-saving, no question. But for chronic degenerative leg pain in elderly patients, the evidence is genuinely troubling. Studies published in the journal Spine have documented complication rates exceeding 40% for complex spinal fusion in patients over 65. 40%. Blood clots, infections, hardware failure, and a condition called adjacent segment disease, where the vertebrae above and below the fused section begin breaking down because the normal mechanics of the spine have been permanently altered. You fix one level and damage the ones next to it. And here is the part that should give every patient pause. Multiple well-designed studies have shown that for many elderly patients with chronic degenerative spine disease, aggressive fusion surgery provides no better long-term pain relief than physical therapy combined with targeted epidural injections. No better, but with dramatically higher risk. I had a colleague, a brilliant spine surgeon, who once said to me, "Sometimes the best operation is the one you don't do." I think about that sentence almost every day. Physical therapy focused on core stabilization and flexion-based exercises. Epidural steroid injections for acute flare-ups. Pain management strategies that preserve function without destroying spinal mechanics. These approaches will not appear on a surgical center's revenue sheet, but for many patients, they offer the same pain relief with a fraction of the risk. Before agreeing to spinal fusion, ask, what does the evidence say about long-term outcomes for fusion versus conservative treatment in patients my age and with my specific condition? And what is the complication rate at your center for patients over 65? Surgery number 5. This is the hardest one for me to talk about. Not because the medicine is complicated, because the consequences are irreversible. Amputation. Specifically, below-knee amputation performed when limb salvage options have not been fully explored. Diabetes is the leading cause of non-traumatic lower limb amputation in the United States. The pathway is tragically predictable. Neuropathy causes loss of sensation. A small wound goes unnoticed. Poor circulation prevents healing. Infection sets in. The infection spreads. And at some point, a surgeon says the words no one wants to hear. We need to take the leg. Here is what makes this decision so grave. Research on diabetic patients who undergo amputation shows that approximately 81% are alive 1 year later. But at 5 years, that number drops to roughly 50%, half. Amputation in an elderly diabetic patient is not just the loss of a limb. It initiates a cascade: loss of mobility, cardiovascular deconditioning, muscle wasting, depression, social isolation, each one accelerating the others. And there is an equity dimension that cannot be ignored. Studies consistently show that diabetes-related amputation rates are disproportionately higher in low-income communities, among Black Americans, and among Hispanic Americans. Not because the diabetes is different, because access to specialist wound care and vascular surgery is different. A patient in a well-resourced urban hospital may see a wound care specialist, a vascular surgeon, and an infectious disease expert before anyone mentions amputation. A patient in an under-resourced community may see a general surgeon who recommends amputation as the first and only option. Limb salvage is a real and growing field. Advanced wound care with negative pressure therapy, hyperbaric oxygen in select cases, revascularization procedures, bypasses, or stents to restore blood flow to the affected area. Targeted antibiotic therapy guided by culture results rather than broad-spectrum guessing. Partial foot amputations that preserve the ability to walk. These options exist, but they require specialists, and they require time. If you or someone you love is being told that amputation is necessary, ask this question before signing any consent form. Has a vascular surgeon evaluated whether blood flow can be restored? Has a wound care specialist been involved in the treatment plan? Have all limb salvage options been exhausted? If the answer to any of those is no, request those evaluations. It is your right, and it may save a leg that someone was ready to take. Before we close, I want to give you 4 questions. Write them down. Put them in your wallet. Bring them to every surgical consultation for the rest of your life. Question 1. If I do not have this surgery, what happens in the next 6 to 12 months? A good surgeon will give you an honest answer. If the answer is, nothing urgent changes, you have time. Time to think. Time to get a second opinion. Time to optimize your health. Question 2. Is there a less invasive alternative we have not tried? Medicine has changed enormously in the last decade. Robotic surgery, endoscopic procedures, catheter-based interventions, intensive rehabilitation. Options that did not exist 10 years ago are now available in most major hospitals. Question 3. What is your personal complication rate for this procedure in patients over 70? Not the national average, your numbers. Surgeons track this. They know their outcomes. A confident, honest surgeon will tell you. If they seem uncomfortable with the question, that itself is information worth having. Question 4. What would you recommend if this were your own parent? I have asked this of colleagues throughout my career. The answer is almost always different from the standard recommendation, and that gap between what a surgeon recommends professionally and what they would choose for their own family tells you everything you need to know about the complexity of these decisions. Let me come back to Raymond. 18 months out from his knee replacement. The knee is fine, no pain, full range of motion. By every surgical metric, a success. But Raymond spent 4 months on dialysis from the kidney failure triggered by the pulmonary embolism, triggered by the blood clot, triggered by the surgery. He is off dialysis now, but his kidney function has not fully recovered. It may never. He told me, sitting on his porch last October, "Dr. Carter, if someone had sat me down and said, 'Here is your knee risk, and here is your body risk, and here is what could happen,' I would have tried everything else first. I would have lost the weight, I would have done the therapy, I would have tried the injections, I would have learned to live with some pain." His neighbor, Frank, same age, same knee, same pain, different doctor. Frank's doctor said, "Let's try 3 months of physical therapy first. Let's get 15 pounds off. Let's try a cortisone injection, then we reassess." 1 year later, Frank's pain is down 60%. No surgery, no complications. Still gardening every morning. 2 men, same problem, different conversations, different outcomes. A surgical recommendation is not a verdict. It is the beginning of a conversation. And in that conversation, you are not a passive recipient of medical decisions. You are an active participant in your own care. The surgeon holds the scalpel, but you hold the choice. And that choice, made with full information and clear eyes, is the most powerful tool in medicine. More powerful than any operation I have ever performed. If this video gave you something to think about, share it with someone who is facing a surgical decision right now. A parent, a spouse, a friend who has been told surgery is the only option. It may not be, and that conversation could change their life. Everything I've shared today is general medical information based on published research and my clinical experience as a surgeon. Surgery saves lives every single day. I have seen it. I have been part of it. I am proud of it. The message of this video is not to avoid surgery. It is to be an informed patient. Your situation is unique. Before making any decision about surgery, please have a full, honest, unhurried conversation with your own physician or specialist. Get a second opinion if you need one, and take every day you need to decide. Good medicine is never rushed. Take care of your legs. They have walked you through every chapter of your life. They deserve a surgeon who explains everything and a patient who asks every question. I'm Dr. Ethan Carter. Stay informed, stay empowered, and never say yes until you are sure.